All right, welcome to the Iowa Ideas In-Depth Week, where this week we focus on mental health. As demand for mental health care in Iowa is increasing, finding paths forward can be a confusing labyrinth of services with dead ends, long lines, and lack of providers to quickly serve those wanting help. What can be done to better serve Iowans? So in today's session, we'll discuss changes to Iowa's mental health and substance abuse districts. We'll talk to Iowa HHS leaders about their plan to change the way that Iowa is delivering mental health and substance abuse treatment and the different regions in the state that provide that. We'll talk about the challenges needed and how I guess these, as well as other ideas, can help improve mental health care in the state. I'm Tom Barton. I'm the Gazette's Deputy Des Moines Bureau Chief, covering Iowa politics, including the Iowa legislature and campaigns. I'll be serving as your moderator, helping to guide today's discussion and conversation, again, as part of Iowa Ideas. Iowa Ideas is a year-round series of content and gathering, including, again, this week's In-Depth Week. Thanks to our presenting sponsor, ITC Midwest, for their sponsorship on all things related to Iowa Ideas in 2024. And thank you to this In-Depth Week's presenting sponsor, Foundation 2 Crisis Services. Just as a reminder, audience members can submit questions to our panelists in the chat box. And again, as I mentioned, today's session is titled Changes to Iowa's Mental Health and Substance Abuse Districts. With me today are Marissa Eyanson. She serves as the Director of the Division of Behavioral Health for the Iowa Department of Health and Human Services. She is a graduate of Iowa State University. Her first job was as a direct support professional in an intermediate care facility for individuals with intellectual disabilities, and she spent her career working in the behavioral health and community-based services field in Iowa. She's worked with the Iowa Department of Iowa Department of Human Services since 2018. And prior to stepping into her current role, she served as policy director for Iowa Medicaid. Welcome, Marissa.
Thanks so much, Tom.
And we have May Hingtgen. She is the Chief Executive Officer of the Mental Health and Disability Services of the East Central Region. May has spent her career as an advocate for people with disabilities, abuse survivors, children, and the elderly. She spent 11 years as the Director of Behavior and Learning Supports for the Dubuque Community School District. In that role, she worked with children who experience behavioral health needs and implemented prevention practices related to student discipline, bullying, and harassment. Since returning to the mental health and disability services field in the fall of 2019, she has worked to support a wide array of services for both children and adults in the East Central region to assist all Iowans to be healthy, productive, contributing members of their communities. Welcome, May. Thank you very much for joining us.
Thanks, Tom. Happy to be here.
And we have Cassandra Collins. She serves as Deputy Director at Area Substance Abuse Council, guiding treatment strategies and transitional housing initiatives. She brings 15 years of experience in delivering mental health care and substance use treatment. Her experience spans working with individuals with intellectual disabilities, offering end-of-life care, and serving as a therapist for youth, individuals, and families. She previously held the position of adjunct professor at the University of Iowa School of Social Work, where she instructed courses on family violence. She advocates for equitable policies, marginalized communities, and fostering trust and empowerment. Welcome, Cassandra.
Thanks, Tom. Thanks for having me.
Great. Again, just a reminder that if you have questions for the panelists, you can submit those in the chat box, and we'll get to as many as our time and discussion allows. So to start off, Iowa Governor Kim Reynolds on Wednesday, just yesterday, signed into law a plan to overhaul and combine Iowa's delivery system for mental and behavioral health services, which advocates hope will improve access for patients. It combines Iowa's 32 mental health and substance use regions into 7 unified behavioral health districts. while placing disability services under the jurisdiction of the Iowa Department of Health and Human Services. The proposal aims to improve a system that both state officials and advocates agree is badly fractured. The legislation states that the new behavioral health services system shall provide equitable statewide access to all services and offer specialized services with a focus on at-risk populations. That includes children, young adults, individuals with disabilities, pregnant women, older Iowans, and those with limited access to financial resources. Some worry the proposal doesn't go far enough to address underlying issues that hinder access to treatment and services in the state, including Iowa Medicaid reimbursement rates. The state would contract with local administrative services organizations to carry out their services in each of the 7 new behavioral health districts. The state would solicit proposals from existing agencies that oversee mental health regions or another public or nonprofit entity in the district to, again, administer the 7 new regions. Marissa, I want to start this conversation off with you. How did we get to where we are today? How was Iowa funded and provided mental health and substance use treatment in the past?
Yeah, thanks so much, Tom. And so, to kind of lay some of the groundwork, starting with maybe the second piece first, just a little bit. Our history for how we funded services here in Iowa is really built on different foundations, ultimately. And that's because Iowa has consistently divided the work that we do when we think about mental health, substance use disorders, and the work that we do ultimately in a prevention, treatment, and recovery spaces. And what I mean by that is that we've just simply had a different form of governance set up for those things. The work of substance use has primarily been with what was the Iowa Department of Public Health previously and is now included within our Health and Human Services umbrella. And it came together with the work that we do in mental health that came from traditionally the Department of Human Services. That work progressed differently over the course of time. And a lot of that difference, what we see in the progress, is really linked into how we fund it. So the mental health and disability services funding historically has been at the county level. Until just a couple of years ago, it was funded by a county property tax levy. And that meant that all the decision and all of the governance and all of what we do in those spaces was ultimately linked to property tax levy and local level decision making. If you have a property tax levy, local level decision making makes a lot of sense. And it allows for a really precise focus, but it also builds fiefdoms where you get different things in different places. We've reached a point in our system that the funding has moved and we no longer want to have these things that are different. So when we cross the county line, something looks different. That really has its legacy in county homes. Iowa hasn't changed its law or its policy as times have changed. We simply deliver different care to people now than we did 75 years ago. And that's the work that we've taken on. As we brought the Health and Human Services work together here as a state agency, it became really, really clear that we needed to look out into our communities and out into our systems and build something that really does bring this work together. In those conversations that happened over the last year or so, as we've brought the agency through the alignment effort, one of the things that rose up was that behavioral health was this focused area of need. People were really telling us exactly what you just said in your opening, that the system itself was fractured and they don't know how to get care. People were questioning the investments at times. Why are we putting all of these dollars here and none of those dollars there? They really honed in with us on a need for prevention and prevention work that is real and really clear pathways. We won't treat ourselves out of a crisis. And we need to be thoughtful about how we invest those dollars. People also honed in into crisis care. And we heard really great examples from the work that May and her colleagues have done at the regional space here in Iowa that's really built crisis care out in our state over the last 5 years or so. But we also heard examples from people who said, Marissa, I hear you talk about this great crisis service system, but it doesn't exist in my territory. It isn't here in my county. It doesn't happen in my community. We need to get to a space that it happens for all Iowans. And so that's the background, right? That's the conversation that's been happening for us here as a state. And then this year, the response to that conversation was the legislation that was introduced by Governor Reynolds this session and signed by her yesterday. Tom, you and I and May got to be kind of there. I don't think I saw you yesterday, Cassandra, but we got to be there. And what an exciting day it is, because this is all of us together launching forward to build something new. It does change our funding structure. It puts those dollars together so that we're thinking about things comprehensively from a funding standpoint, but it also builds the new system. It builds the framework. And one of the really great things about that build that I'm really excited to do is it builds a framework of shared responsibility. It says that we're all in this together. It won't be delivered upon people by the Iowa Department of Health and Human Services. Instead, we have a consistent feedback process that will build a statewide plan and ultimately bring all of our stakeholders to the table together to really build something that's robust and real and true and speaks to the needs that we have at a local level, but also speaks to the needs that we have that are statewide and allows us to really target those efforts.
So the biggest concern that I've heard from lawmakers, as well as some mental health advocates, is that the state is once again rearranging, but not investing the resources that Iowans need who are seeking mental health and substance use treatment, that there's no new money for mental health services included in the law. Can you address that?
Yeah, absolutely. So there's a couple of things that are at work there that I think sometimes are just confusing for people. The first is that the way that a state operates a budget, for instance, treatment work here in Iowa is primarily funded by Medicaid when we think about our behavioral health treatment space. The work that we do in non-Medicaid public fund is really safety net services. And those safety net services are important. They're things like crisis care. They are things like services for folks that are not otherwise eligible for Medicaid, for instance. But they are not the primary funder. Medicaid funds about 60% of the treatment services today in Iowa for behavioral health. And what we've been really, really fortunate to see over the last couple of years is significant investments in the Medicaid space. In 2023, we raised the Medicaid reimbursement rates to essentially match the market here in Iowa. We did significant analysis of what are the payer rates essentially amongst other payers, amongst private payers here in the state. What are the rates in our surrounding states? We made recommendations to the legislature, and the legislature responded to those recommendations with a significant investment that raised those rates on average by nearly 55% in the Medicaid space. That's a significant additional investment into our behavioral health space here in Iowa. This year, they once again raised rates in the Medicaid space. That included additional investment for specialized work that's happening in psychiatric medical institutions for children to really address high acuity needs for kids, something else that's been on the to-do list that we've been hearing from Iowans, and an additional $2.1 million to invest into behavioral health rates, including for our community mental health centers. So there's been significant investment in that Medicaid space. That's not included in this bill. Now, the reason this bill didn't come with additional money is because today there is current money that's in the Regional Incentive Fund. And those are dollars that our MHDS regions have been unable to spend. So they've reverted to the incentive fund here that's just held in the Treasury at this point in time. And the reason for that reversion isn't because people are not doing their jobs and trying their hardest. The reason is because the system itself that's built today and that old language that we're moving away from contains some really interesting barriers for our local entities who are trying to make these consistent investments. And so once we start to remove those barriers, we gain access to those incentive fund dollars, and we can really contemplate things like statewide need for 988, for instance. There's a need for investment in that space for sustainability. We've been able to fund it through federal funds thus far, but investing for sustainability is going to take a space that's true and ongoing. So we think about statewide needs, we think about available dollars. We also gain access or ultimately a view that's comprehensive. And that allows us through a state planning process to put back in front of our legislators in a reasonable and ongoing sort of way. Here's all of the things that we can do with the money that we have today, but here are the things that we cannot do. And we ask our decision makers to help us make sure that we can do those things in the future state.
I want to bring May and Cassandra into this conversation. And May, I guess I'll start with you. I guess, what does the current landscape look like for you in providing mental health and disability services? I guess, what are the biggest struggles and challenges right now in Iowa?
Yeah, thanks for asking, Tom. I think I would piggyback just a little bit on what Marissa was just talking about as far as like areas in the law that right now that prevent us from doing things that we need to do. And I think Cassandra would agree with me that right now in the Iowa law, well, I guess it might change as of yesterday, but previously in the law, we were not able to pay for substance use treatment for people who experience issues, with substance use disorder out of our regional funds, out of the mental health and disability services funds. And we know that a lot of Iowans, a lot of Americans experience both issues with brain health as well as substance use disorder. And treatment for them has been siloed in the fact that, there are certain funds that could support people with Cassandra's organization, and then certain funds that we can use to support people at providers in our region and across the state, all the regions, for their brain health. And it's something that for us, we've been advocating for the past 2 years, to say, let's get caught up and make sure that when people have both concurrent brain health and substance use issues, that they can receive treatment at one place instead of maybe going to separate places and then even perhaps having separate treatment plans. Can we have one treatment plan to make sure that a person's needs are being met holistically rather than separately from different organizations? So that's been one of the struggles for us, is that disconnect between the funding and the policy for substance use and brain health services. So, yeah.
Great. Are there some real life examples or maybe common issues or problems you run into that you can provide?
Oh, sure. I mean, I think often about a gentleman who's from our area, who has a diagnosis of an intellectual disability, a diagnosis of a brain health or a mental health issue, and has substance use issues. And on top of that, also is diabetic, right? And so his family has really struggled to find appropriate placement for him, a place that supports all of his needs, medically, mentally, and physiologically through the substance use needs. And he's been to several different facilities in Iowa who have tried really hard, and I'm not going to say that people aren't trying, but just the barriers that we have with policy and funding that keep those things separate has not allowed us to truly develop integrated care that we would like to develop. So I think, in the future state, that this gentleman will have opportunities for greater outcomes and to be able to live a little bit more independently and successfully with the variance of mental and physical issues that he experiences.
Cassandra, I have a similar question for you. I guess, what does the current landscape look like for you in providing treatment and recovery support for Iowans who are seeking help for substance use disorders?
Sure. And I think a lot of what we see is an alignment, like May spoke about, just on the substance use side. So currently we provide comprehensive substance use and recovery services to individuals. We're working towards being able to provide mental health services as well. However, in the current space, we rely on our community partners when we have individuals with those co-occurring disorders. And so what we know about brain health in general is individuals that have substance use disorder. So there's approximately 20 million in the United States that have it. 37% of those will also have a mental health diagnosis. And the same thing with mental health. There's approximately 42 million individuals in the US with mental health diagnoses, and over 18% of them also have substance use. So nearly every person that walks through our door is, struggling with mental health and substance use. And what we're currently running into is when we begin to provide substance use services, either right at admission or as we build that relationship with an individual, it becomes very clear that they need mental health services as well. And we struggle to find them timely. We know we have great community partners that are doing great things, but they have waits. They have wait lists, and it can be several months until they can even get an appointment on an outpatient basis. Pretty recently here, we had a patient who came in for treatment, was doing really well. And as she, went on in her treatment journey, she started having some psychosis present. And we have struggled to have her needs met. Insurance companies say, she needs a higher level of mental health care. Our question is, well, where do you suggest she get that and also receive substance use treatment at the same time? Because she's doing phenomenal when it comes to working on her substance use treatment. And so it would be great for those things to be able to occur simultaneously. And I think being able to join with community partners and do those things at the same time would be hugely beneficial and impactful for the patients that all organizations are serving at the same time together.
We talked a little bit about kind of the mental health and disability services regions and kind of how they're set up. Can you talk a little bit about the 19, I guess, substance use regions and how they operate and maybe how that would change with this new law?
Sure, I can tell you what I know, and then Marissa might be able to share even more. So currently, Iowa is split up into we call the substance use areas. And so there's 19 areas that have an integrated provider. So we receive funding to provide substance use services for those who are underserved. So yes, we can bill Medicaid, private insurance, but we do have the capability to access that funding to provide care to individuals who otherwise would not be able to get care. So our understanding is that with this realignment, there will be 7 regions in total for both mental health and substance use. So we would be grouped in with all of the brain health providers, if you will. And so we don't know necessarily what that looks like. We know that there will be a service organization identified to disperse that funding. We don't know the details of that. We don't know how it will be split up. So Marissa, maybe I will punt that over to you if you have more information than I do.
Sure. And I don't have a lot more information, but I can give a little more framework. And the reason I say that I don't have a lot more information is because this really gets into those spaces that over these next few months, we ask Iowans to come to the table with us and help us design that future state system. The simplest way of understanding the change when we think about the integrated provider network and the change when we think about substance use, Cassandra, is you get a may in the future state. And that's a link that's been missing for our substance use work. For our providers in the integrated provider network, their connection right now comes back to a relatively small group of humans here at the state's Department of Health and Human Services, my team. And what we don't have is local connection to help support our provider network out there in the communities, absent kind of this leapfrog sort of thing that comes back to us here as a state. The other thing that we're thinking about, I think, when we think about the work that's happened already within the integrated provider network, is that it's given us a really clear line of sight about the need to build prevention, for instance, and how important it is to build prevention as an area of specialization. It's not an afterthought to treatment. It is its own thing that deserves focus and attention. And Cassandra, I know you guys know this as well. It's the other side of that equation is the need to build recovery. And it's the same sort of conversation that work really is real and true and although connected, right, separate from the work we think about when we're delivering treatment. We've learned that through the integrated provider network's work over the course of about the last 5 years now. As our providers have really dug in with us to make sure that folks in those service areas have everything, basically, because that's kind of the charge in the IPN. What we really need is local connections and collaborations built to really hone into that service array, and then really to the work that we're trying to do in a lot of our provider spaces right now in real time, broaden our perspective to the greatest degree that we can. Prevention is built in some of our addictive disorder spaces. The shortfall for us in the current state is Iowa has never successfully built really robust mental health promotion or the prevention arm of what we think about in the mental health care lane. Recovery is being built right now in real time, but we haven't built it as far yet. When we think about the recovery pieces that come with serious and persistent mental illness, for instance, how we maintain folks for longer term in their homes, in their communities, in a space that isn't necessarily service provision, like longer term services and supports, but is true recovery and support. That's a spot that gives us a real opportunity to continue the conversation about enhancing peer recovery, for instance, about enhancing peer support, and about bringing some of those pieces together.
Just a quick reminder again that audience members can submit questions to our panelists in the chat box. Marissa, another piece of this that kind of has flown under the radar, hasn't gotten as much attention, and this was mentioned yesterday during the bill signing by Kelly Garcia, Iowa's Director of Health and Human Services, But another, I guess, change included in this law is that it moves disability services provided by the state's mental health and disability service network to the Department of Health and Human Services Division of Aging and Disability Services. I guess, can you talk a little bit about, I guess, how that would work? And May, I'd be interested in getting your thoughts as well as a director of one of the regions that currently has, disability services under, I guess, its umbrella.
Absolutely, Tom. So you're exactly right that it's exciting work as well and has flown a bit under the radar. Part of the reason for that is because the essential framework for that movement, as we think about putting aging and disability services together and really thinking more comprehensively about longer term services and supports for Iowans, that framework is primarily built because the framework exists on a national level and exists here in Iowa as aging and disability resource centers. The second part of that, though, and the very important piece, is this. Current state aging and disability resource centers are not really supporting folks with disabilities today because they've been built primarily within Iowa's area agencies on aging, and their focus has been primarily the needs of the aging population. So this is enhancing that work. It's also been a complicated space for our regions, and May will give you guys more description about that. And part of the reason is because it's been kind of locked in a really weird tug of war, honestly, between the Medicaid funded program space and then what do we do with these state dollars? And it was kind of falsely siloed in a strange sort of way. The reality is that we're often kind of stumbling over each other. We're serving same folks, but systems themselves aren't working together to do that work comprehensively. Medicaid is and always will be the primary funder for longer term services and supports. Over 90% of the dollars in that lane is going to be Medicaid money. But we will also always have some folks who are going to rely on longer term services and supports, even if it's a short term sort of space, and that fund has to come from the state. And this is a real space of vulnerability for us because at the federal level, they don't care who paid for those services. What they care about is that individuals with disabilities get access to the care that they need. Our system is built with a lot of peculiarity today, and we're not able to do that and fulfill that promise. And so bringing the work together, giving it consistent line of sight, and then essentially, kind of placing a driver's seat here that says we're in charge of this and it's our responsibility, is ultimately to ensure that folks with disabilities have access in real time to all of those wider scope services and supports they need.
May, your thoughts on the changes as it pertains to that disability piece?
Yeah, I mean, I would say that what is happening, and I think Marissa did a nice job of explaining like kind of the why and how we got here. And what I would say is that this change allows us an opportunity to maybe iron out some of those wrinkles in the system in which we have different systems who are helping people when we should be helping all Iowans, right? And the opportunity for us to partner with the area agencies on aging is so ripe here, and for us to capitalize on what they do, share what we do in order to make sure that people get the services they need. And I think that pairing together with disability services with aging is important in Iowa. I mean, we're a rural aging state, and just as important as allowing people with disabilities to live with dignity is allowing older Iowans to live with dignity for them to age in place. And the opportunity here to perhaps reduce some isolation that they experience by the partnerships that we can build with our area agencies on aging, I think is going to ultimately result in better outcomes for Iowans.
Yeah, I do want to get to an audience question, and it's a question that I also have on my list for the panelists. The question is, with all the changes happening statewide with this bill, are there potential snags or difficulties that might be anticipated? I don't know who maybe wants to go first on that one.
Well, I spend a lot of time thinking about potential snags, Tom. And so I think the answer is of course, right? Of course, there's potential snags. The things that I think about right now are very, very much probably the really like detail level sorts of things, because ultimately the goal for July 1 of 2025 is don't break it, right? There are things that are working, a lot of things that are working today. And the goal for the beginning is don't break those things. What we're trying to do, of course, is build a system that's easier, better for all. So I worry about someone who loses access to a thing that they need on July 1 of 25, right? I worry for our providers being able to navigate through and making sure that our payments are all sound and that sort of thing. But part of the worrying is also, frankly, the planning, because the way that you address those things is really robust mapping. For instance, you make sure that you've really taken a hard look at all of the dollars in the current state and where all of the dollars are going, and then you map it all to the future state, and you make sure that every one of those loops is closed. That's the work that we've been charged with here to make a transition. And then the other piece is that I really want to get it right. And really that's the reason for building in such a robust process for stakeholder feedback as we build a new plan.
And Cassandra, I guess, what benefits do you foresee from the new legislation, and what are some drawbacks or challenges that you foresee with this new law?
Cassandra, you can go first.
I would say we are cautiously optimistic. I think anytime you are looking at upgrading a system and you're talking about, equality of services for individuals that may not be getting that currently, I think it's a win. And I think, having the conversation of bringing substance use and mental health as well as prevention and recovery all in the same space and the same conversations leads us to be hopeful. And I think part of the challenge piece that we're just concerned about is, whenever a system changes, I think we always worry about our patients first. How are these changes going to impact them? How are the continuity of the services they're already receiving going to be impacted? Hopefully they're all in positive ways. But I think it's the unknown of what that looks like for them. And also for our employees, how is this new system going to, contribute to or potentially take away from the stability of the organization, or all organizations as they currently exist. And so, I would love to say that what we see in a year is a really strong system and a lot of strong partnerships where agencies and individuals who are doing great work every single day are just strengthened in what they're already doing and strengthened in their partnerships to provide that alongside, other organizations. I think one thing currently as it stands is the timeline it feels concerning to us right now, right? We're a year away from a pretty drastic change, and we have some key events that we are aware of, but not necessarily the details of what those look like and the impacts to our patients and potentially our staff. And so I think that's where for us we start just voicing some concern and hope as well that we'll be able to be at the table and sharing our thoughts and our expertise and what we're seeing.
I would echo much of the same. I think that really there's opportunity, right? There's opportunity for the relationships, and there's opportunity for comprehensively us addressing the well-being of Iowans, whether it's children or older adults. And so, and then no matter the issue that they're facing, whether it be substance use, brain health, disabilities, perhaps even brain injury, right? So a form of a disability. So I think that because that was specifically mentioned in the law, which needs to be universally applied as well. So the opportunities for us to work together, I think we're in essence a collaborative state. And so I think we can get this work done. As far as like concerns for us, it like Marissa said, like doing it right, making sure that people don't lose services. There's a certain level of ambiguity right now, and there will be for the next few months. And that's easy for some people to deal with and hard for some to deal with the ambiguity. And so that creates a little bit of anxiety. We are moving into, in all of the regions in the state, moving into a year where strategically, it's really important for us to ensure that we continue to deliver services as we are authorized as an MHDS region to deliver services and provide the support with integrity, the same integrity and passion and commitment that we've done for the last 10 years, as well as to think strategically about the future. And so, as Cassandra said, like, feels like it's going to be a lot of work for the next year, but we have a lot of committed people, I think, all across our state to get the work done.
Marissa, we've heard, a lot of questions about, I guess, ambiguity as to how this law is going to get implemented. Can you talk a little bit about that? I guess, what are the deadlines and the stages as to how this is going to progress?
Yeah, absolutely. And so one of the things that I sometimes describe for folks as we think about this next year in particular is a little bit about like how implementation works. The good thing about thinking about that is that we don't have to make it up because it exists. We implement things all the time. And so the first stage of implementation is what we're doing right now. The law was effective upon enactment. And that first stage is exploration. This is landscape analysis. This is a time when we bring Iowans together, right? This is pretty soon. We're gonna head on the road here from Iowa HHS, and we're going to do town halls, and we're going to do roundtables, and we're going to do those both virtually and in person. And the goal of that endeavor is to gather people's feedback. Because what we've built here is a framework for shared responsibility. And what it means is that I'm not going to sit here at my desk and write the state's plan. Every Iowan has to show up and tell us what we need and tell us where those gaps are and help us understand how to best close those gaps. Because I am a firm believer, frankly, that I can't do it best from here. That will happen best out in communities. By July 1, we have to publish, we as HHS, we have to publish a transition plan. And the transition plan is really us laying out some of those gateways ultimately, so for providers like Cassandra, for our regional partners, what are some of the things that they can expect to see? What are some of the things that Iowans can expect to see as we start to make our way through this transition process? By August 1st, we have to publish the finalized version of what the district maps are going to look like. So folks have seen that we have a draft version that we've had out in the community as we've been sharing this information since January around what the behavioral health alignment bill might be. But now that it's real, it's time to finalize what districts will look like. And part of what the bill called on us to do is to do that again in the public space and to take stakeholder feedback. And so that will be built in to those conversations that we'll be having over the course of the summer. Once the map is finalized, what's happening in the background is that we're also doing that current state system mapping. We're thinking about all the services that exist today. We're making sure that we understand where the funding is coming from and where the funding is heading, because that gets us ready to procure for administrative service organizations. And that will happen in about the fall. And the procurement process is where we put forth a request for proposals. And we will ask that entities that wish to do this work with us going forward put in their very best proposal for how they'll meet all of those needs. Those needs are going to be the result of all of that system mapping and all of that feedback that we've gathered over the course of the summer. And by the end of this year, we'll make a decision, and the decision will award ultimately to those administrative service organizations for each of the districts that are defined here in Iowa. And that goes immediately into how do you install this thing? When you install something, you're getting it ready to go. You're doing the concrete work. This is ultimately where, like, a lot of the rubber starts to meet the road there, right? Because you're really thinking about making sure you have the resources to support all that planning that you laid out before. And you're making sure that you're establishing really clear gateways for people in those administrative service organizations, especially to prove that they're ready to go on July 1st of 2025. One of the important things that threads through this entire first year process is a requirement that HHS is doing this endeavor right out in public, and that we're also posting this information and reporting out on it in a way that people and decision makers can see how it's going. What that results in is on July 1st of 2025, all together, we as a state will stand up a new system to support behavioral health. It won't be perfect on day one, and implementation is awkward. That's all there is to it. But what you do is you maintain those lines of communication, and you make sure that people know what to do, where to go, who to call when something didn't work, because what we're ultimately concerned with is that care continuity space, right? Making sure that patients get to what they need, making sure that our administrative service organizations are really truly ready to answer the call, making sure that the movement, when we think about disability services, is consistently grounded so that folks, especially in those longer term services and supportive spaces, they have ongoing care that they need. And then as that system established, you get to new normal. What we're building here is a framework that helps us do further innovation, because once we've established this new framework and it's well connected in our public health lens, for instance, and it's well connected to the work that's happening in aging and disability services, and it's well connected to the other system building that we think about when we think about HHS work going forward here in Iowa, we can then further innovate within that system because it becomes part of our continuous quality improvement process, and it becomes built in to the statewide planning endeavor. And so it doesn't get frozen in time, right? We're not building the system that we need in 2024 and then stuck with it in 2054, which is kind of the space that we sit today. Instead, we're trying to build a system now that has the ability to meet the needs now, but also in the future.
So a question we have from an attendee, they're wondering what that stakeholder engagement, what that process will be, and they're wondering if there will be a committee similar to ccbhc, Stakeholder Engagement Committee?
So I love that question, Tom, because it's exactly the lines that we're thinking along as well. And so we felt like our endeavor in the Certified Community Behavioral Health Clinics and effort over the last year, which was a planning grant endeavor, it really paid dividends for us. And what it resulted in is a plan that we put forward as the department initially in the planning grant that had significant changes along the way, thanks to our stakeholder committee and the feedback that we received from the public. We want to do it again in this effort. And so that's a really good example of a time that we've seen already that it can work, and how we see that paying off. What we've put forward to the federal government for ccbhcs is an incredibly robust application to become a Medicaid demonstration state, which gives us an enhanced federal match and more money in the system to build very true, brightly lit centers in our communities for behavioral health care. An incredibly important piece of how this work becomes real. I'm really optimistic that we'll be awarded, very hopeful, I should say, that we'll be awarded. Optimistic feels, gosh, it's presumptive. I like the application. We did an amazing job. We did it all together. And I'm hopeful. And this is what we want to do again. So it's a really good comparison. And the answer is yes. It was a long answer to get to yes.
That's fine. But and then for those who aren't familiar, just quickly, what are these community-based health centers?
Yeah, absolutely. So they're exciting because Certified Community Behavioral Health Clinics, or CCBHCs, are the acronym that folks will hear and hopefully become familiar with. What it really represents is a couple of things that sometimes people have a little more familiarity with. And so one way to think about it is if folks are familiar with federally qualified health centers, or FQHCs. At the federal level, when CCBHCs were initially conceived, they were conceived of as behavioral health FQHCs. And what it really is building is concentrated space based on a pretty robust system of requirements, about 110 items, individual items that are required in order to be certified as a CCBHC. That requirement is both from the federal but also from the state's level. So the federal requirements are in place, and then the state is required to certify that all of those things are met by any of the clinics that we as a state certify as a CCBHC. What it's ultimately getting us in a demonstration space, which is a Medicaid funded mechanism, is enhanced funding to do really significant work that brings the work of mental health and substance use treatment together in an outpatient clinic. It has strong requirements around the co-occurring disorder space, for instance, strong requirements around how we manage that care, includes connection points into crisis care and crisis services. It brings the work together in a really, really meaningful way, and ultimately says that regardless of where you live or who's paying for it or what your need is, when you enter the door of a CCBHC, the clinic is required to serve you. They're required to meet those needs. And if those needs happen to be co-occurring, or if you happen to be a veteran, or if you happen to be a person who's uninsured, none of those things changes. The requirement is you are welcomed, essentially, and your needs are met. That is an incredible investment by the federal government, an incredible shift in the work. It's the most significant thing that has happened here in the United States since the initial conception of community mental health clinics, which happened under the Kennedy administration.
Maybe you've addressed this, but another question from the audience is, how will the new alignment process prioritize addressing disparities in mental health and substance use?
And so I'll apply some interpretation to what I think this might be asking. And I think it kind of references maybe a bit to what Cassandra's thoughts were earlier as well. So one of the things that's been complicated for us in a space when we think about how we treat substance use disorder, for instance, is that so often in substance use disorder spaces, the disease itself has a degree of like judicial involvement, or a person that's been arrested, or the disease itself is illegal. And what that also creates is an even more enhanced stigma. So part of what we're really contemplating here and what we're really doing when we bring the work together is we're really thinking about full scope parity for behavioral health. We're saying that addictive disorders are diseases. And they're diseases, I mean, to use like the language that May often uses is brain health. They're diseases that are happening in our brain, but brains are part of our bodies. And so no different than a person with cardiovascular disease, for instance, or no different than a person with a broken leg, you need treatment. And you have a right to that treatment, and that we as a state and as people, ultimately, we need to treat that need for treatment with similarity. We need to make sure that providers are reasonably reimbursed for their education and their care for individuals. We need to have an equal focus when we think about prevention, because we won't treat our way out of crisis. And we need to support folks in recovery so that, treatment doesn't end when they walk out the door of our clinic, for instance, but that they can maintain their long-term recovery at home and in the community and have the support that they need. So that's how we do it, right? We bring the work together, and then we address it as ultimately a public health issue that engages all of us. This isn't something that's just siloed into kind of like back alley care for behavioral health, where we don't want to talk about it anymore. We're gonna kind of do it out loud, and ultimately make sure that people get equal access to care.
And then another question, recipients of services are worried or concerned of longer wait times, gap in services whenever a redistricting happens, such as was evidenced with domestic violence and Agency on Aging, HCBS waivers. How can such fears be alleviated?
Yeah, I haven't heard those direct fears as of yet. So a lot of times the things that I've heard thus far have been really more folks telling me about how hopeful they are because they see some of the gaps in the current system, including a lot of our providers that have waiting lists today. But to that end, I think that any change process does create fear, right? The fear automatically, whenever you're talking about change in status quo, is that it'll be worse. What I think we're trying to do to help address that fear is, first of all, since the bill was signed yesterday, now it's time to really start talking about this work, right? It's real now. And that's what we're doing, right? That's part of your timing here today, and this week especially is so fantastic for this. Part of it is also to make sure that folks know that we really are truly inviting everyone to the table to help us build this system, because that's how we do something that is right by all Iowans. That when you have those fears and the fear is concern for loss or concern for missed connection or concern that you weren't thought about when the system was being built, that sort of thing. The way to alleviate it is to hopefully join us in some of these stakeholder sessions this summer or in the planning process ongoing, and really help us make sure that what we build is what we need.
Yeah. May and Cassandra, I guess, what do you hope comes of this new transition, and how do we get there?
Well, I think many of the things that we've already talked about, but I hope that we address well-being for Iowans in the more comprehensive manner, that it's equalized or it's more equitable, and no matter what issue they're facing or where they live in Iowa, that we have that standardization and we have that access and we have the availability of services. And, getting there, obviously it's the planning and it is the seeking the input and it's collaborations, but it's also continued concerted effort to support workforce in our state. Some of the access issues that we've had are because of capacity, right? From a workforce standpoint. So I think it's been ongoing since the pandemic, and there obviously isn't the magic answer, because we have a lot of smart people who would have figured it out, in our state, in our country. But I think it's a continued commitment to supporting our networks and the workforce needs that they have, so that they're stable and that we can make sure that services are delivered.
I agree. A lot of what May said as well. And I do want to touch on too, we have briefly kind of mentioned it today, but I do think, this realignment is really an opportunity not only for providers, for brain health providers, but also Iowans to stand up and talk about stigma a little bit. Here's our opportunity to say we value brain health in Iowa. We value your voice and your experience. And we want to hear how all providers can do better and how we can serve Iowans better. And I think it's very basic in terms of you have a right to access care in a timely manner, and you have a right to access quality care where your providers are talking to one another and you're not having to repeat your story several times. And, having some of that behind the scenes work occurring seamlessly, where providers have time to call one another and be in touch with one another, in addition to, seeing patients. So I hope one thing that comes out of this is, Iowans feeling seen and heard, and aren't as fearful to take that first step in seeking help when they need it, and they're welcomed, when they seek help. And one thing I did just want to echo what May said in terms of workforce, absolutely since COVID, and I think the emergence of work from home jobs, because I think work from home jobs are really nice, but the work that we do is not from home most of the time. And so, one of the things I would hope for in the realignment is a discussion about how do we support the workforce that we have, who have really been doing the hard work already and really putting blood, sweat, and tears some days, into helping people. How do we retain them, and how do we continue to attract individuals who can help people? Because I think it's continued to be a struggle, and I think we all need to work together to solve that as well.
Okay. Another question from the audience, following up on something, Marissa, you were talking earlier about. So if Iowa is awarded a certified community behavioral health center demonstration by the federal government, how is the implementation of the ccbhc model being contemplated, I guess, alongside the move to the 7 unified behavioral health regions in 2025?
Absolutely. So the potential award for a ccbhc demonstration was actually kind of baked in, because that was part of the reason that now was the time to really contemplate how we bring this work together. So again, ccbhc modeling is bringing care delivery together when we think about treatment and outpatient treatment spaces in particular for mental health and substance use disorder. And so if we get this opportunity to build that focused space and to really think about how we network it and build it out over time here in Iowa, to be kind of a safety net, right? Like it becomes that safety net provider space. That is the thing then that starts to open the door to saying, gosh, if we're going to do that, then maybe we need to think about the whole thing. And that's what really kind of foundationally brought us into some of this conversation. So it's kind of a key piece, I guess, that's already baked into the model. If we're not awarded for demonstration for July 1 of 2024, I'll be a little bit sad, and then I'll wake up the next day and the work goes on, because what we're going to continue to do is we're going to continue to do the training and the technical assistance work that we've been doing with our whole network of providers to build ourselves up to ultimately be awarded in the next cycle. So if we're not awarded this round, we're just going to keep on trucking until we can kind of guarantee one of those spaces for ourselves, because we think the model is real, and we think the work is true. And we think that being able to pull down that enhancement and be able to offer our providers a prospective payment to do that work is a really important piece of how we're going to knit this safety net together.
Another question from the audience. So with these changes, attendee is wondering if the state will be working with the MCOs to make mental health care more accessible for individuals with Medicaid. They mentioned that the current system creates many barriers for providers and insured members to access mental health care. They talk about many providers not accepting Medicaid because the process is too lengthy to get reimbursed, which then causes a shortage of providers for residents who have Medicaid.
Yeah, absolutely. So one of the pieces that I think that we contribute to that conversation when I think about this specific work within the behavioral health framework is that it is too hard for providers to do their work today. And part of that is related to having multiple layers of licensure, certification, and accreditation. You have to approach through multiple doors, including a couple of different state departments, a handful of divisions, and some outside entities. To be able to stand up a business and provide full scope behavioral health care today is too hard. After you've completed that scavenger hunt, you have to approach 3 separate managed care organizations in order to enroll your providers, first with the Medicaid program and then credential them with the organizations. We can do better than that as a state when we think about removing administrative red tape. That's one of the very specific things that we can work on together. I think our managed care organizations will be happy to join us in that endeavor. I don't think they probably like it either. And so that's a piece that removes real red tape or real administrative burden for our providers. And we need to build the system so that we can do it. The other thing that it makes me think of is just kind of the reminder of what we talked about right at the top, which is it's 2 parts really, right? So first of all, managed care organizations work for us. They work for the Iowa Medicaid program and they do work on our behalf. And so the big lever, the big change space really is thinking about Medicaid when we think about that. And the way that we do that is really being thoughtful about our rates, for instance, and making sure that our rates are sufficient. And that's the work that we've done over these last couple of years, is to really investigate our reimbursement rates in the Medicaid space and really try to place those dollars in a way, and with the support of a wide array of decision makers, right? Be able to place those dollars in a way that we're fully funding the work that needs to happen.
Right. Unfortunately, we are running out of time. So as I wrap up this conversation, I want to ask you, what can Iowans do to move progress forward on this issue? And where can people go? What's available for those who are in need for behavioral health services? And I'll just kind of throw it to the group.
I'll jump first, and then I hope May and Cassandra will join as well. Jumping first, just because I do have some specific asks for Iowans, Tom, and it's a couple of things. First of all, I am an Iowan who is here today because I received early intervention and support. I think it's important that we say that in the public space, and I want all Iowans to feel like they can. It's also a reason that I do what I do, right? It's important to me that we build a system that ensures that every other kid in the state of Iowa has the same shot that I did. That's how we ultimately save lives. And so this work is incredibly important, and I want people to join us. I want people to tell their stories, and I want them to join our upcoming stakeholder and town hall sessions and tell us how to do this work and how to do it best. Because that's the way ultimately that we're going to build a system together that is better than maybe what we could even imagine today.
I would say that I would love for all Iowans to just have an awareness that that whether it's a behavioral health need or a disability need, that it's okay and that help is available. We have to continue, which I think has been a great momentum in the last 4 years, about being open on the discussions to say it's okay to need help and help is available to you, and to also then to be able to rely on the fallback, the commitment of those of us who do this work, that we're going to be there for them. And so whether it's each individual Iowan themselves or someone they know, because we all know somebody, even if it's not ourselves, who could use help in some way from those of us who are sitting around the table and committed to this work.
Much like they said, the town halls, the opportunities for stakeholder input, Iowans are the stakeholders. They are the receiver of the services. And so you have to speak up and share your truths, share your experiences, and share your thoughts about how we can improve what we do for all of you. And just like May said, every single person knows someone who is touched by brain health, or has been in need at some point in their life of a service. And so they're not here to advocate for themselves, you know, please come to the table and advocate as a loved one.
Great. Well, thank you for joining us today at In-Depth Week. We appreciate your questions and your comments. I want to thank our panelists, Marissa Eyanson, Hingtgen, and Cassandra Collins. Tomorrow we'll be discussing the topic, working to reduce stigma and avoidance of care. I want to thank our sponsors, ITC Midwest and Foundation 2 Crisis Services. And a reminder that all of the sessions from the week will be available for replay at iowaideas.com. And don't forget to save the date and register for the full Iowa Ideas Conference on October 10th and 11th. Again, more information and to register for that is available at www.iowaideas.com. Again, thank you. Thank you to our panelists, our sponsors, and everybody for joining us. Really appreciate it.
Thanks so much, Tom.
you.
Thank you, guys.